Hello guys, I hope you're well. And today we're talking about how does one find motivation to not procrastinate or to revise for this exam. Now, a crucial thing to understand is you and I are both human and we both go through emotions. We both have our own personal situations, our own personal living situations, different families, we all belong to different communities. So all of these factors come into play with revision, because if you live with family and you're trying to revise, whether you live in an apartment where there's a lot of noise, this will affect you. Anyway, the summary of the answer is a lot of us are struggling to study. And I'm not saying this to be defeatist or, oh, you know what, stop studying. I'm just saying that you just need to keep going. Whatever method you have for studying, just keep going. Anyway, let's get to revision and let's start. So first and foremost, I wanted to go through atenolol. So let's quickly go to that. And first and foremost, with atenolol, there are a few important things that you need to know. So with beta blockers, there are some beta blockers which are cardioselective, and this is very, very important to know. So some beta blockers which are cardioselective would be the ones that have the mnemonic of Batman. So Batman being bisoprolol, atenolol, metoprolol, acebutolol, and nadolol, if I can remember correctly. Now, most of the time when I'm revising, I get confused between whether it's acebutolol or whether it's nadolol or nebivolol that are cardioselective. So that one always catches me out. So let's get to beta blockers. So an important point with beta blockers is the fact that it can be used for migraine prophylaxis. That's a very, very important point. Also, when we look at beta blockers, the bronchospasm issue is very, very important. So the fact that beta blockers are cardioselective, then this means that you may be able to use them in asthma because they are less likely to cause bronchospasm. But as you can see, as it says, beta blockers, including those considered to be cardioselective, should usually be avoided in people with a history of asthma, bronchospasm, or a history of obstructive airways disease. So a obstructive airways disease would be COPD. However, when there is no alternative, a cardioselective beta blocker can be given to those patients of caution. So cardioselective beta blockers such as Batman may be given with caution to some patients. In cases, the risk of inducing a bronchospasm should be appreciated and appropriate precautions taken. This is very, very important. So cautions are diabetes, myasthenia gravis. So when it comes to myasthenia gravis, this is a very, very important topic. And in some medication, there are a few medications that can cause myasthenia gravis, and we'll go through that in a bit. So it can mask hypoglycemia, and with certain drug families, if you give sulfonylurea beta blockers, it can mask tremors. Now, I have a question for you guys. Which drug families can mask hypoglycemia? So beta blockers can, and if you give sulfonylureas, they can mask tremor. Also, which drug groups are cautioned in myasthenia gravis? So the drugs are tetracyclines, statins, and a few other drug classes. But statins is a important one to remember. For certain statins like Rosuvastatin, you need to treat the hypothyroidism before initiation of Rosuvastatin. Now, let me show you the evidence for that. So, Rosuvastatin is a big one when it comes to hypothyroidism, and statins in general, obviously, because you understand that it can change hepatic enzymes, and muscle breakdown or myalgia can be caused by differences or alterations in creatine kinase or alanine transaminase, ALT, ASTs. ALT, AST, liver enzymes, so be careful of that. So here you go. Statins are very infrequent reports of myasthenia gravis. So when studying, understanding that there are a few drug families where myasthenia gravis is cautioned is a crucial point. So some medications you need to monitor LFTs as well, and this would make sense, and you can actually connect the dot. Any drugs that sort of are cautioned in myasthenia gravis, there is a chance, even a small one, where you might need to monitor LFTs. It's not all the time, but this is a good sort of guess if you guys don't know the answer. So watch out for that in the exam. And a very, very crucial question the GPC like to ask is, which of the following is a monitoring parameter? Which of the following is not a monitoring parameter is also something the GPC like to ask. So you need to know which of the following is a side effect, which of the following is not a side effect, and which of the following is a monitoring parameter, which of the following is not a monitoring parameter. So all of these sorts of lines of questioning the GPC will like to ask you, and we're not even getting towards the MEP. Now let's quickly polish the MEP quickly. With MEP, I've already briefly talked about on live streams and in videos the fact that the schedules of controlled drugs are very, very crucial to know. CD2, CD3, CD4. And knowing which CDs have to be in the record book, so the CD register book, and knowing which CD3s should be in the cabinet and have CD storage requirements or not. So to quickly brush over it, CD controlled drug invoices need to be retained for 2 years. Now, some controlled drugs that are in Schedule 3, such as temazepam, must be in the CD cabinet. Also, other drugs like midazolam, which is the Schedule 3, is not in the cabinet. It's kept in wherever all the POMs are, so it doesn't have any special storage requirements. Also, Schedule 3s generally, as far as I remember, are not in the record book, so the CD register book, and that's important. Also understand that the CD register is electronic and paper format. However, more pharmacies these days are going to the electronic controlled drug register, and people have varied opinions on that, whether it's good or bad, but that's irrelevant to the exam, whether it's good or bad. Now, when it comes to prescription POM requirements, this is also an important point. Knowing what makes a prescription valid, age, if under 12, date of birth, do you need the name of the medication, what's the labeling requirements, etc. Is keep out of reach and sight of children is it a legal requirement or is it good practice? I understand that. As far as my own research, keep out of reach and sight of children is not a legal requirement. It is good practice according to RPS. I need to verify that again because I'm not too sure about that. Now, when it comes to vet prescriptions, vet legal classifications are something that you also need to know. POM-V, POM-VPS, all of the legal classifications that are with vet prescriptions are important. Signed orders, what is a signed order? The things I'm mentioning now, if you don't know it, please go over it now. And these are all extremely high weighted things. Anyway, let's get back to beta blockers quickly. So as we've just mentioned, with beta blockers, you have infrequent reports of myasthenia gravis. So let's go through it. There have been a very small number of reports of new onset or exacerbation of pre-existing myasthenia gravis or ocular myasthenia. And this is very, very important. So symptom onset range from a few days to 3 months after starting statin treatment. Healthcare professionals are advised to refer patients who present with suspected new onset myasthenia gravis symptoms after starting a statin to a neurologist. The statin may need to be discontinued if risks outweigh the benefit. So from this sort of line of questioning, you can sort of predict that the GPC might ask a question which will quiz you. If you have a patient with myasthenia gravis or the myasthenia gravis is new whilst taking statins, would you refer to A&E or would you refer to GP? And I'm asking you guys, what do you think? So these types of questions are very, very crucial and they do ask about. So sometimes, as far as I'm aware, they may give you a question which is, they generally say the options aren't ambiguous, but some questions, if you don't know a lot about the topic, there might be two are options that you believe is equally sort of viable, equally effective. Okay, so back to sort of statin. So here it says healthcare professionals are terminologists, and professionals are also advised to counsel patients and their carers to inform their doctor before taking a statin if they have a history of myasthenia gravis or ocular myasthenia, as it may exacerbate the symptoms. So this to me is a referral to GP. Now don't quote me on this, could be wrong here. So the problematic is seek immediate medical attention if they develop severe breathing or swelling problems. Inform their doctor if they experience symptoms such as weakness in the arms or legs that worsens after activity, double vision, drooping of the eyelids, difficulty swallowing, or shortness of breath. So these are sort of red flag symptoms that you need to look out for. Obviously, caution for all statins, risk factors for muscle toxicity, including myopathy or rhabdomyolysis. Now, let's have a quick discussion about this. So, why is it that liver problems are cautioned whilst taking statins? So, we already understand this by now, that with statins, when we have muscle breakdown symptoms, when we have myalgia, when we have rhabdomyolysis, we need to monitor creatine kinase levels, ALT and AST levels. So, generally, when you have muscle breakdown or muscle pain, you would measure creatine kinase. If the creatine kinase levels is more than 5 times the upper limit of normal, then you would halt the statin or you would not initiate an alternative statin. So you would re-measure the creatine kinase levels after 7 days, that's 1 week. And if the creatine kinase levels are still greater than or equal to 5 times the upper limit of normal, then you would need to investigate the reason why. So you need to investigate the reason why, and this could be because the muscle breakdown is a sign of rhabdomyolysis. Now, if it's not if it's not greater than or equal to 5 times the upper limit of normal, then that would mean that the muscle breakdown is not because of the statin. And then you would kind of refer to GP and see what the underlying reason of the muscle breakdown could be. It could be other reasons, maybe a different chronic condition, etc. Also, you need to measure ALTs and ASTs, and these are crucial as well. So this is how you can remember that cautions are myasthenia gravis. Generally, as far as I'm aware, if there is myasthenia gravis, it's a referral to GP, not A&E. Depends if they have any breathing or chest problems, and this is very, very crucial. So, dealing with statins, hypothyroidism should be managed adequately before starting treatment with a statin, as I mentioned. So here it says muscle toxicity can occur with all statins, whether they're high intensity or not. And of course, you'll need to know which drugs are high intensity. However, the likelihood increases with higher doses and in certain patients. Could be elderly patients that have, maybe less muscle, or, patients that have renal impairment problems, history of liver disease, cirrhosis, high alcohol intake, etc. Let's look at the side effects. So you have pancreatitis, which I don't believe it's that important to know. I would say important ones are like hyperglycemia. So statins can cause hyperglycemia, hence the diabetes mellitus, myalgia, as we've talked about. So statins should not be discontinued if there is an increase in the blood glucose concentration. Now, why? Because the benefit vascularly, so the vascular benefit outweighs the problems associated with the diabetes risk. If patients develop symptoms such as dyspnea, cough, and weight loss, they should seek immediate medical attention. So we have gynecomastia specifically for rosuvastatin, cough, dyspnea, and SCARs, which are sort of skin reactions. Adequate contraception is required during treatment and for 1 month afterwards. Now let's pause here. I can guarantee you, most people taking this exam would not remember that point about contraception. So when I talk about the exam, sometimes the Gphc will ask you maybe a handful of questions that are quite niche, that maybe they know that people won't notice. But obviously, that is not to say that the Gphc is making the exam intentionally difficult. They're not. 70% of exam takers do pass, so don't worry. But the point is that you will need adequate contraception whilst taking a statin. And I'm referring to all statins in this case. So look out for that when you're studying. So conception and contraception, adequate contraception is required during treatment and for 1 month afterwards. So for pregnancy, statin should be avoided in pregnancy. Discontinue 3 months before attempting to conceive, as congenital anomalies have been reported and the decreased synthesis of cholesterol possibly affects fetal development. So when it comes to teratogenicity, a very, very crucial point or recipe to know whether a medication is teratogenic is how does it work? If you have a drug that affects the natural biological mechanisms in the body, like antifolates, vitamin K, drugs that are involved in vitamin K, so vitamin K epoxide reductase inhibitors, such as coumarin, such as warfarin, these generally are teratogenic. Now, why? Because you need vitamin K for the fetus development. You need sort of other vitamins and minerals for sufficient fetal development. Whether it's folate synthesis, so folic acid synthesis that is needed in a fetus. So these are very, very important. So statins are HMG-CoA reductase inhibitors. So you can imagine why they're going to be problematic, because they affect cholesterol synthesis. Even though there is a fetus, cholesterol is still needed in the fetus. So this is very, very important to talk about. As you can see, statins should be avoided in pregnancy and discontinue 3 months before attempting to conceive, as congenital anomalies have been reported and the decreased synthesis of cholesterol possibly affects fetal development. So the way we're going to remember this is statins affect cholesterol synthesis, thus affecting fetal development. Very, very important point. Breastfeeding manufacturer advices avoid, and there's no information available on that. Now, hepatic impairment, where it gets interesting. In general, manufacturers advise caution, risk of increased exposure in statins. And this makes a lot of sense. Now, why? Because when we take statins, especially if you have muscle breakdown, you will have elevation of creatine kinase or ALT ASTs. So that's very, very crucial. Now, onto renal impairment, avoid if creatine clearance is less than 30. A large portion of the exam will ask you about creatinine clearance. If you do not know the creatinine clearance to at least 3 medications like metformin, nitrofurantoin, and let's say dabigatran, these are just 3 ones off the top of my head. So metformin is less than 30 milliliters per minute, dabigatran is less than 30 milliliters per minute, and nitrofurantoin is less than 45 milliliters per minute. However, you may prescribe with caution for a short duration of time of 7 days if someone's eGFR is 30 to 44 milliliters per minute according to the NICE CTS. Also bear in mind nitrofurantoin is teratogenic and may cause neonatal hemolysis, and you need to be careful in acute porphyria as well as patients who have G6PD deficiency. So watch out for that in the exam. Anyhow, in the exam, they will ask you about medications and their contraindications in eGFR. So people keep asking me, "Oh, teacher, what should I revise?" You should know the eGFR of the main medications, especially the high-risk ones. Serum ranges are important. Lithium 0.4 to 1, phenytoin is 10 to 20. I don't believe you should know the reference ranges because you generally will be given it, but knowing it is a plus. Knowing interactions, the main ones, knowing MHRA warnings, very, very, very crucial. And these are a few of the important topics that I personally believe is important. And if you look at past papers, the past papers will agree with what I'm saying. Anyway, so back to statins. So dose adjustments, obviously because of renal impairment, you'll need to have a dose adjustment. So initially 5 milligrams once daily, avoid 40 milligrams daily if creatinine clearance is 30 to 60 milliliters per minute. So let's look at monitoring requirements. So before we start, I've seen many questions that ask literally, which of the following is a monitoring parameter for statins or methotrexate? Or which of the following is not a monitoring parameter? So watch out for that, guys, in exam. If you have a question that says which of the following is or is not, pay attention to the wording. Please do not lose silly marks by Gphc writing which of the following is not a risk factor, or which of the following is the most appropriate, which of the following is the least appropriate, which of the following is not a monitoring parameter. So be careful. Now, I can't remember in the exam if they highlight the not. I don't want to say they do because I generally cannot remember. It's been a year since I did the exam. But anyhow, please do not get caught because of such a silly mistake. I know you'll be stressed in the exam, but you need to stay focused. You need to sort of, in clinical, generally time isn't an issue. So people generally do not have issues with time. However, you need to just be careful in the exam. Now, so some monitoring requirements is before initiation, at least one full lipid profile should be measured, including total cholesterol, triglycerides, HDL cholesterol, non-HDL cholesterol, and ADL cholesterol concentrations, and repeated 2 to 3 months after starting or changing treatment. Baseline TSH in patients with symptoms of underactive or overactive thyroid and renal function should be assessed. So right now we have pretty much proven that if you have a patient, according to the BNF, that has a underactive or overactive thyroid, so hypothyroidism or hyperthyroidism, then you'll need to do a baseline TSH level, so monitor for TFTs, and renal function should be assessed. That is depending on how their thyroid state is, so watch out for that in the exam. So let's look at LFTs quickly. We've already briefly discovered LFTs. I will need to go over that more in other videos. So liver transaminases should be measured before initiation and repeated 2 to 3 months after starting or changing treatment, and then at 1 yearly unless indicated at other times by signs or symptoms suggestive of hepatotoxicity. Patients with serum transaminases that are raised but less than 3 times the upper limit of normal should not be routinely excluded from statin therapy. So these are about serum transaminases, not CK. Before initiation of statin treatment, creatine kinase concentration should be measured in patients who have had a persistent generalized unexplained muscle pain, tenderness, or weakness, etc., if the baseline concentration is more than 5 times the upper limit of normal. So as you can see, guys, this is something we've already discussed. So when it comes to creatine kinase levels, if the patient has muscle pain, this could be muscle pain or rhabdomyolysis due to the statin. Now, the only way you can test that, it's a bit like a car. So if you have a vehicle and you have a rattling noise near the engine bay, it could be a ball joint, it could be another problem, it could be a gasket issue, God knows, there could be many, many problems with a car depending on the noise it's making and where the noise is originating from, whether it's the middle of the car or whether it's a suspension issue. Anyway, the point is, for creatine kinase, the only way you can sort of understand where the muscle pain symptoms arise from is by measuring a naturally available biomarker, and that is just creatine kinase or ALT/ASTs. So these are biomarkers that are elevated if there is muscle breakdown internally in vivo in the body. So these are biological biomarkers, and that's very, very important to understand. So for creatine kinase, you would see if the creatine kinase levels is more than 5 times the upper limit of normal, then you would repeat after 7 days, as we've already explained. So some patients may present with an extremely elevated baseline creatine kinase concentration, for example, because of a physical occupation or rigorous exercise, so at the gym. So if you have a patient that has just come back from the gym, or they're champion powerlifters, or they do jiu-jitsu, or they do boxing, this physical occupation may naturally elevate their baseline creatine kinase concentration. So you need to be careful of that. Patients at high risk of diabetes mellitus should have fasting blood glucose concentration or HbA1c checked before starting statin treatment and then repeated after 3 months. So watch out for that. And manufacturer consider routine monitoring renal function when using 40 milligrams daily dose. So I appreciate it a lot, guys, for watching this, and shout out to anyone that has watched this whole video. My apologies if it's long, but let me stop it here so it won't be longer than this, and thank you so much, guys.